Gastrointestinal decontamination. Gastrointestinal decontamination refers to the practice of functionally removing an ingested toxin from the gastrointestinal (GI) tract in order to decrease its absorption. When a patient attends hospital after ingestion of a toxin, one of the first considerations is whether anything can be done to prevent or reduce absorption. Gastric decontamination has been a cornerstone in the management of overdose for decades. Historically, many approaches have been adopted, including gastric evacuation, forced emesis or gastric lavage, intragastric binding, most commonly by single or multi-dose activated charcoal, or speeding transit of toxins to decrease total absorption time, whole bowel irrigation or cathartics. As clinical practice has evolved and understanding of the efficacy, risks, and benefits of decontamination have grown, many practices have fallen out of favor. Following is the in-depth description of the methods. The various methods of poison removal from the gastrointestinal tract include emesis, gastric lavage, catharsis, activated charcoal, whole bowel irrigation. Emesis. The only recommended method of inducing a poisoned patient to vomit is administration of syrup of ipecacuanha, or ipecac. The current consensus is that syrup of ipecac must not be used, except in justifiable circumstances. 1. Syrup of ipecac. Ipecac is used in the emergency treatment of certain kinds of poisoning. It is used to cause vomiting of the poison. Only the syrup form of ipecac should be used. A bottle of ipecac labeled as being ipecac fluid extract or ipecac tincture should not be used. These dosage forms are too strong and may cause serious side effects or death. Only ipecac syrup contains the proper strength of ipecac for treating poisonings. It acts by local activation of peripheral sensory receptors in the gastrointestinal tract. Central stimulation of the chemoreceptor trigger zone with subsequent activation of the central vomiting center. Dose of 30 ml, adult, or 15 ml, child, followed by 8 to 16 ounces, i.e. 250 to 500 ml approximately, of water. The patient should be sitting up. If vomiting does not occur within 30 minutes, repeat the same dose once more. If there is still no effect, perform stomach wash to remove not only the ingested poison but also the ipecac consumed. Ipecac should not be used to cause vomiting as a means of losing weight. If used regularly for this purpose, serious heart problems or even death may occur. Although certain medicines should not be used together at all, in other cases two different medicines may be used together even if an interaction might occur. In these cases, your doctor may want to change the dose, or other precautions may be necessary. Tell your healthcare professional if you are taking any other prescription or non-prescription, over-the-counter, OTC, medicine. 2. Other emetics. The only other acceptable method of inducing emesis that is advocated involves the use of apomorphine. Given subcutaneously, it causes vomiting within 3 to 5 minutes by acting directly on the chemoreceptor trigger zone. The recommended dose is 6 mg, adult, and 1 to 2 mg, child. Since apomorphine is a respiratory depressant, it is contraindicated in all situations where there is likelihood of CNS depression. 3. Mechanical. In some cases, stimulation of the posterior pharynx with a finger or a blunt object may induce vomiting by provoking the gag reflex. Unfortunately, such mechanically induced evacuation is often unsuccessful and incomplete, with mean volume of vomitus about 1/3 of that obtained by the other two methods. 4. Obsolete emetics. The use of warm saline or mustard water as an emetic is not only dangerous, resulting often in severe hyponatremia, but also impractical since many patients, especially children, refuse, fortunately, to drink this type of concoction and much valuable time is lost coaxing them to do so. Copper sulfate induces emesis more often than common salt, but significant elevations of serum copper can occur leading to renal and hepatic damage. It is also a gastrointestinal corrosive. Zinc sulfate is similar in toxicity to copper sulfate, and has in addition a very narrow margin of safety. Gastric lavage. Gastric lavage is a gastrointestinal decontamination technique that aims to empty the stomach of toxic substances by the sequential administration and aspiration of small volumes of fluid via an orogastric tube. It was previously widely favored method that has now been all but abandoned due to lack of evidence of efficacy and risk of complications. There is no certain evidence that its use improves outcome, while the fact that it can cause significant morbidity, and sometimes mortality, is indisputable. Lavage should be considered only if a patient has ingested a life-threatening amount of a poison and presents to the hospital within 1 to 2 hours of ingestion. Indications: 1. Gastric lavage is recommended mainly for patients who have ingested a life-threatening dose, or 2. Who exhibit significant morbidity and present within 1 to 2 hours of ingestion. Lavage beyond this period may be appropriate only in the presence of gastric concretions, delayed gastric emptying, or sustained release preparations. Some authorities still recommend lavage up to 6 to 12 hours post-ingestion in the case of salicylates, tricyclics, carbamazepine, and barbiturates. Contraindications: initial resuscitation incomplete. Risk assessment indicates good outcome with supportive care and antidote therapy alone. Small children. Corrosive ingestion. Unprotected airway where there is a decreased level of consciousness or risk assessment indicates potential for these complications during the procedure. Hydrocarbon ingestion. Procedure. Explain the exact procedure to the patient and obtain his consent. If refused, it is better not to undertake lavage because it will amount to an assault, besides increasing the risk of complications due to active non-cooperation. Endotracheal intubation must be done prior to lavage in the comatose patient. Place the patient head down on his left lateral side. Mark the length of tube to be inserted, 50 cm for an adult, 25 cm for a child. The ideal tube for lavage is the lavacuator, clear plastic or gastric hose. Sometimes, the Ewald tube is most often used, which is a soft rubber tube with a funnel at one end. The preferred route of insertion is oral. Passing the tube nasally can damage the nasal mucosa considerably and lead to severe epistaxis. Lubricate the inserting end of the tube with Vaseline or glycerine, and pass it to the desired extent. Use a mouth gag so that the patient will not bite on the tube. Once the tube has been inserted, its position should be checked either by air insufflation while listening over the stomach, or by aspiration with pH testing of the aspirate, acidic if properly positioned. Lavage is carried out using small aliquots, quantities, of liquid. In an adult, 200 to 300 milliliters aliquots of warm, 380 c. Saline or plain water are used. In a child, 10 to 15 milliliters per kilogram body weight of warm saline is used each time. Water should preferably be avoided in young children because of the risk of inducing hyponatremia and water intoxication. It is advisable to hold back the first aliquot of washing for chemical analysis. Lavage should be continued until no further particulate matter is seen, and the efferent lavage solution is clear. At the end of lavage, pour a slurry of activated charcoal in water, 1 gm per kilogram, and an appropriate dose of an ionic cathartic into the stomach, and then remove the tube. Disadvantages, complications. The amount of toxin removed by gastric lavage is unreliable and often negligible, especially if performed after the first hour. There are few, if any, situations where the expected benefits of gastric lavage would exceed the risks involved and where administration of activated charcoal would not provide equal or greater efficacy of decontamination. It can lead to pulmonary aspiration, hypoxia, laryngospasm, mechanical injury to the gastrointestinal tract, water intoxication and hypothermia. Distraction of staff from resuscitation and supportive care priorities. Thank you.